which is an online Abhyankar sir is a consultant psychiatrist and head of the Child Guidance Clinic at BJ Wadia Hospital for Children at Parel. He's also the chief psychiatrist and director at the Manas Hospital, a psychiatric nursing home in Sion. Sir is the member of the Election Commission at the IPS. Sir has been the past president of the IPS West Zone, past president of the BPS, past honorary general secretary of the IPS from 95 to 97. Sir is the chairperson of the Rehabilitation Psychiatry Specialty Section of the Indian Psychiatric Society from 2003 to 5. Sir has been a past chairman at the awards committee at the IPS West Zone and multiple awards and research papers. Welcome, sir. Dr. Sheryl John, ma'am, she practices at LH Hiranandani Hospital, Powai and Holy Spirit Hospital, Andheri East. Her areas of interest are adult psychiatry with a special focus on women's mental health, consultation liaison psychiatry and de-addiction. Currently, she's on the board of trustees of FIAMC. She's also the chairperson of the NDPS task force of the Indian Psychiatric Society. She's a visiting faculty at multiple teacher training courses across the country. She's into mental health awareness and destigmatizing mental illness, and it's driven her to deliver lectures across the length and breadth of the country. She's a passionate advocate of mental health, as she has conducted a myriad of programs through various social media platforms as well as multiple community and school-based mental health programs. Welcome, ma'am. I would now request the chairpersons to please introduce our speaker.
Today we are fortunate to have Vivek Benegal online with us. Vivek Benegal and Atul Ambekar. Vivek Benegal from NIMHANS and Atul Ambekar from AIMS, Delhi. They are the two big names in addiction psychiatry in India. Both have devoted their entire career for the field of addiction medicine. So we are fortunate to be Dr. Vivek Benegal is a retired professor at NIMHANS. He was head of the Center of Excellence of Addiction Medicine at NIMHANS, and currently he is professor in the Kasturba Medical College, Manipal. I would request Dr. Sheryl to introduce about the topic today.
Thank you, sir. Thank you, Dr. Shobha Nair and BPS for having me here as the chairperson. At such an important topic, how the world around us sculpts our brains to understand vulnerability and resilience. I think the concept of world around us only has changed in the last few decades, right? The world around us was initially our home or our close environment, but now I'm sure Dr. Benegal will talk to us about the extended environments, our social context, cultural context, the epigenetics factors, how all these factors are going to impact our brain circuits. Neurons that fire together, wire together is a very common norm, and I'm sure over the course of the next half an hour we learn how our environment is changing our brain and how do we become more resilient rather than being more vulnerable. So thank you, Dr. Benegal, for joining us even though it's remote, and we're really looking forward to learning from you. Yes, we can.
Okay, thank you. So thank you very much to the Indian Psychiatric Society for calling me, and I'm so sorry. to be able to put forward to the audience. Number one is uh, the need to look more closely at the social dynamics of health. To understand our problems better, the problems of mental health better, and the mental illness also, as well as to look for solutions. And I'll talk about why we really need to look for newer solutions. This also will focus on why the distinction between bio, psycho, social, which we keep trotting out, this has become a tired definition, is redundant. The second idea that I really want to convey is how does our environment talk to our brains, and how does it modify the structure, their function, and also the psychological abilities that we use to engage with the world around us and to operate on the world around us, and how difficulties in this can lead to vulnerability or to resilience. The third idea I will briefly touch upon, I hope I will have the time to do that, is how can we use this understanding to modify the way we work. And I will illustrate with a lot of examples from this particular study that is illustrated on your screen, the Pathways to Resilience in Mental Health, which we call PARAM, which is an ICMR task force, which is a study actually which has been going on for almost 10 years now, where this is a neurodevelopmental cohort, and where the aim of it is to actually follow brain development from -6 months from the antenatal period into adulthood, that is 30 years. And we are very focused on looking at how genomic influences, genetic influences, and the exposomal influences, that is the exposure to environment across the lifetime, how both these effects shape our brain in different ways, and obviously leave a mark on our psyche, on our psychological abilities. Just let me see whether I hope the slides are moving. Okay. Now, you will appreciate that, we in the mental health field are in a little bit of a crisis. While the last 20 years have brought some progress in biomedical understanding of psychiatric disorders, the fact that it is immutable, that the constructs, the disease constructs are overlapping, and that there is a polygenic basis of psychiatric disorders that explain why some people are more at risk than others. It's also given us a better understanding of complex neurobiology, but it's simultaneously exposed the limitations in our ability to translate our acquired knowledge to the bedside into effective clinical targets. And the promise of personalized prediction and treatment still remains out of reach in routine clinical practice. What has also happened is frontline pharmacological treatments have remained largely unchanged since they were first developed in the 20th century. Treatment resistance affects upwards of 60% of our patients, and the pharmaceutical industry has largely withdrawn from psychiatric drug discovery in the last 20 years. Now, the question is, I think something that if you, the slide is not working properly, but then depression, for example, which is the leading cause of ill health and disability worldwide, has had a recorded increase of more than 18% between 2005 and 2015. In fact, a 65% increase in antidepressant use between 1994 and 2014 was accompanied by a 33% increase of suicide rate from 1999. There's another factoid on this slide which you're not able to see because I'm actually not working from my slide presentation, but increased use of antipsychotics has actually led to worse prognosis in psychiatric disorders. So the question that we really need to ask ourselves, are our patients really getting better? Are they better off than 100 years ago? And the answer probably is depressingly no. The trend towards poorer long-term outcomes for persons with major mental disorders as compared to the era before the modern psychopharmaceuticals. Do our patients really get better? This is a umbrella review of more than 100 meta-analysis, which was done very recently, and it shows that most of us of our treatments confer only small benefits overall for both types of intervention, whether they are pharmacological interventions or whether they are behavioral psychological interventions. And combining them gives it a little bit of additional gain, but this is also small in terms of effect sizes. So the overarching picture is that there is limited additional gain for both psychotherapies and pharmacotherapies over placebo, with ceiling response rates of less than 50% and most not exceeding 30 to 40%. So we seem to be trapped between two not very effective but not to be questioned dogmas, the tablet and the talk therapies, which are rationalized by flawed theories of neurotransmitter soup or a patchwork of different psychological ideas propagated by warring ideologies. The targets have become very simplistic. They're categorical, non-overlapping diagnoses, which are constructed on arbitrary, polythetic rules, which ignore other symptoms or presentations. For example, if you're making a diagnosis of ADHD, your diagnostic criteria don't talk about things like rejection-sensitive dysphoria, which is very commonly found in people with ADHD. It doesn't take into account the other symptoms other than those 9 listed there. And it dismisses all suffering which is below the arbitrary thresholds. And sad to say that what we consider evidence-based medicine is primarily based on the evidence of the difference of means of two artificially defined distributions, normal versus affected. And that is what is our gold standard. What we tend to basically do is we tend to ignore the social dynamics of health. Although there is a compelling evidence that the risk of developing any mental health condition is absolutely linked to our life circumstances. There is a higher burden of psychiatric morbidity, which is disproportionately experienced by those who are closer to the to those who are marginalized, who are poor, who live in poorer economic and social circumstances. Conversely, poor mental health also suppresses life chances, how long we live and the quality of years lived. So these two work hand in hand. And improving population mental health by designing effective prevention strategies is a goal that we should be following. Investigating the importance of psychosocial factors in causing mental disorder, unfortunately, has remained a peripheral focus for scientific discovery, as also for clinical psychiatry. What do I mean when I'm talking about social determinants? At the individual level, there are things like socioeconomic disadvantage, early life adversity, childhood adversity, loneliness, social isolation, enforced migration, racial discrimination, sex-based inequalities, inequalities experienced by sexual minorities, etc. Then you have social determinants which operate in the wider social circumstance, like neighborhood disadvantage, inequality, problems with social capital, fragmentation, physical environment, pollution, etc., climate change. I will now spend about 4 or 5 minutes showing you some of the examples from the study that I talked about, the Param study, to show how some of the social dynamics of health operate through the brain to change our psychological abilities, to change our vulnerabilities to psychopathology. For example, this is a paper of ours which came out about 2 or 3 weeks back, and at a global scale, this is based actually on data from a consortium where we have also contributed data, and from about 1.5 lakh MRI scans across different human societies, what we find is that poverty seems to distort brain development. Macroeconomic conditions of a country are reflected in its inhabitants' brains and may explain the different incidence of brain disorders across the world. In fact, this particular paper, we found that higher human development is consistently associated with larger hippocampi, more expanded global cortical surface areas, and increased inequality is most consistently associated with delayed development of specific brain areas which are responsible for learning, for judgment, for a whole host of psychological abilities. Similarly, something we can consider soft science, country-level gender inequality from the same data set we find is associated with structural differences in brains of women. Gender inequality is associated with worse mental health and academic achievement in women, and this is fairly well known. But our data set shows that gender inequality is associated with differences between brains of men and women, and they suggest a potential neural mechanism underlying the worst outcome of women in gender unequal settings. Early life stress, for example, working through inflammation, affects cognition. So children whose mothers had higher levels of prenatal oxidative stress have greater cognitive problems and, say, autism-related behaviors at 36 months. Similarly, children whose mothers had higher inflammatory markers, during pregnancy, are more likely to suffer, poorer cognitive development in their later years. In fact, prenatal immune origins of brain aging are being talked about. For people who had adverse levels of maternal inflammatory cytokines, 50 years later, they seem to have, worse outcomes as far as aging is concerned. Exposure, for example, in this particular study to pro-inflammatory cytokines in the uterus was significantly associated with differences in brain activity and connectivity 50 years later. Similarly, and this is work by colleagues of ours who found that maternal inflammation during pregnancy is associated with a higher risk of ADHD in children at age 10. This is a paper of ours where we looked at how childhood adversity seems to disrupt typical maturation of the default mode network. And the default mode network, as you are aware, is where the sense of self is stored. So the frequency of childhood adversity was strongly associated with, altered patterns and aberrant growth of the default mode network. I'm just going through some of these to give you a teaser of, how the environment actually, changes brain development and, works through that to change behaviors, to change psychological abilities. This, again, is a paper of ours where we were able to demonstrate that children who grow up with greater social adversity have blunting of cortisol later on in life. And blunting of cortisol means that when faced with stress later on in life, they are not able to deal with stress properly, and then they decompensate and are more likely to have, anxiety, depression, etc. And this was linked to changes in genetic expression because of epigenetic modifications that had happened, post exposure to the stressor. Worse mental well-being, for example, has been associated with increased exposure to ultra-processed food consumption. So, the more children have Maggie and, a whole lot of these ultra-processed foods, the greater their chances of, poorer mental well-being. This is a particular paper of ours, which hopefully, will come out in a few months, where we were able to demonstrate that exposure to PM 2.5, which is one of the particulate matter 2.5 angstrom, which is one of the constituents of air pollution. The children who are exposed to air pollution have poorer cognition, and this occurs through a variety of factors. But very fascinatingly, children who have higher socioeconomic status or better nutrition are protected against this. In fact, this effect happens through changes that occur in the development of gray matter and white matter. So you would have got the idea by now. What I'm trying to say is that exposure to some of these social dynamics of health works through brain development, alterations in brain development, to change brain networks, to the activity of brain networks, which are then manifested in the psychological abilities that we have, which we use day to day to deal with our day-to-day environmental demands, as well as our acute environmental challenges that we have. So you can see this direct pathway between the outside and the inside. Similarly, and I'm going to go fast a little here because I'm taking a little bit too much time, but I just want to show you the kind of research that is there. Temperature impacts on hate speech outline. The greater the temperature extremes, whether it is heat or cold, seems to be associated with greater online hate speech. This is a paper which shows how increased temperatures increase suicide rates in India. I especially wanted to show this particular slide, and you find that the earlier the exposure to smartphones, greater the risk of developing psychopathology. And this is something which has been reported by several groups. This particular paper is by colleagues of ours at Sapiens Lab, who were able to show that mental well-being consistently worsened with earlier age at first ownership of a smartphone or tablet. And problems with suicidal thoughts, feelings of aggression towards others, sense of being detached from reality declined most steeply and significantly with older age of first smartphones. Similarly, this is again another paper of ours which shows that short and long-term exposure to increased air pollution increases risk of depression and anxiety among Indian adults. This is actually taken from data gathered from the National Mental Health Survey. So it's a fairly large data set, and because we had access to satellite data and their exposure, 20-year exposure to air pollution, we were able to model some of these effects. Okay, I'm just going to go past it because this is more of the same. The reason why we really need to be serious about and understand some of these is that there is future shock waiting for us. In fact, the World Economic Forum brought out a global risk perception survey, and they found that some of the global risks ranked by severity over the short term, for example, in 2 years, as well as 10 years, are things like misinformation, disinformation, extreme weather events, societal polarization, interstate armed conflict, inflation, lack of economic opportunity, involuntary migration, etc. And these will all have their effect not just on the adults, but remember, these will have their effects on children who are unborn. These will shape unborn children's brain development, and you're going to see it for the young people there. You're going to see it reflected in these young people's growth and development. You're going to see it in the psychopathology that comes in the next 20 years. So, it sounds very, very creepy, but be prepared. So some of the things that we now need to look, so that's one segment over. We really need to look at some of the determinants of brain health across life course, and because some of our solutions will come from that. For example, improving physical health, improving or creating healthy environments, increasing safety and security, improving learning and social connection, improving access to quality services, etc. Now, psychiatrists, we as a breed, have often been very unkeen, not wanting to get mixed up in some of these so-called soft interventions. But if you realize that these are actually very, very important drivers of mental illness, would you not want to position yourself? Perhaps you are not going to be able to provide direct interventions, but would you not want to position yourselves so that future generations have a better chance at better mental health? Uh, so I will very, very briefly touch upon this because I have a number of slides here, but I gather that there is not too much time and we are also running late. So how does the external environment shape brain networks and functioning? The quick answer, without going into a lot of details, is that variations in the brain network developmental program lead to deviations in acquiring psychological abilities which we use to engage with and operate upon the world. So the variations in our psychological abilities are due to variations in functional brain networks. These shape our responses to our external and internal environmental challenges and give rise to vulnerability to mental illnesses. How is the brain network constructed and how is it maintained? It is shaped by two forces. One is it is created by the genomic instructions which are there, in our genes before we are born, about how to make a brain. But importantly, and of course there are variations in this genetic book, so that your brain and my brain are different because there are genomic variations that are normal. But more than that, what is important is that the exposome, that is the entire range of environmental exposures which we face from the time we are a fetus. In fact, even before that, from the time our mothers, our grandmothers' lives, these across the lifetime keep changing our genetic expression and keep changing this instruction to make a brain, so that there are changes which happen in these developmental trajectories. What I also want to impress, and I will show you one or two slides of that a little later, is that the exposome actually interfaces with the genome via multiple pathways. One very important pathway is the stress inflammation pathway, which also involves stress, inflammation, and microglial activation, which then sculpts the brain and is maintained through epigenetic modifications in gene expression. I'll also explain why I'm saying that. So basically, you have program-dependent brain development. This is pictures I asked ChatGPT to make for me. And you have experience-dependent development, where the sculptor who makes the brain, has to change the design because of various triggers which occur in the environment, especially in early life and also across the lifetime. I'm not going to go into some of these things, except to say that some of these exposomal factors are things like nutrition, maternal stress, infection, neurotoxins in the environment, childhood adversity through the lifetime, and these keep modifying your brain development program. This slide is obviously not working, but what I wanted to show in this slide, because there are animations in this slide which are not working, is that a very major force is how the microglia, change or shape our brains. So microglia actually influence neuronal proliferation, migration, etc. Basically, the creation of the structure of the brain and contribute to the entire shaping of the CNS. But maternal inflammatory activation during pregnancy can alter fetal brain development, acting through activated microglia. This alters the shape and the structure and the function of the developing brain, and therefore, what happens to you across life. But the microglia can also train the fetal immune system to respond to stressors in an exaggerated manner later in life. So a trained or primed immune system, when it faces stress later in life, goes into hyper activity and keeps restructuring the brain, which explains why when we face stress later in life, that can be so difficult and dangerous. And these are hard coded by epigenetic edits to the blueprint for brain construction. I'm not going to go through these things. I will just, unfortunately, let me just explain this slide. So basically, the genomic instructions function to actually create your neurodevelopmental trajectories. They are responsible for how your brain is created, its morphology, its function, etc. And these give rise to your psychological capacities. This is called program-dependent development. Okay, but what also happens is that exposure to environmental variables, which happens during the maternal fetal period, which happens during adverse childhood experiences, adolescent adversities, adult adversities, and senescence, these keep modifying the structure and function of your brain, and both these additively give rise to the risk for neuropsychiatric disorders and psychological distress, as well as compensatory behaviors like substance use, etc., etc. So there are multi-level influences on mental health. Mental health is not determined by a single factor, but a complex interplay of biological systems across a lifetime. Now, the controversial idea that I talked about in the beginning is that if inflammation is such a major driver of how the brain is created, how vulnerability to illnesses, both mental as well as other illnesses, whether it's cardiac, diabetes, etc., is created, could anti-inflammatory interventions early in life prevent or also reduce the risk for later mental disorders? Stress inflammation is a common mechanism which links multi-stress exposure to brain sculpting. This raises intriguing ideas for universal public health interventions. So, I'm heading into the last stage of my presentation. What should we be doing? One is we should be looking with this new data, with this new information, to see whether we can actually prevent the common vulnerability states. And this could be done using anti-inflammatory nutrition, anti-inflammatory behaviors which reduce inflammation in the mother, parenting interventions which are known to reduce inflammation, etc. And we have actually started, we've been funded to look at doing interventions starting from the prenatal period. The second thing that we would want to do is to prevent. And prevent by upskilling and building resilience from childhood, working with teachers, working with parents, and increasing control of cognitive abilities and emotional states, providing young people with the protective scaffolding of activities of daily life, which have, actually gone out of style for most children these days. Helping children deal with cues from the social environment and not learn their cues from social media or games on their phones, helping them make sense. And that is a very important thing we as psychiatrists need to do, because the human brain, after everything else, needs to make sense. The default mode network needs to be able to make sense of its world. So how can we do it? Through engaged parenting, coping skills training, reliable, consistent adult mentoring, which is what I was talking about, promoting socialization, creativity, building a sense of self and purpose, self and the world. I know Dr. Vani is there, and this is a shout out to Dr. Vani if she's in the audience. This is what I'd hoped to have discussed with her. Adding movement in everyday life, on-field games, team sports, which are now totally impossible because most schools don't have playing fields, and we've eaten up the playing fields. Nutritional support, initiate consistent patterns of sleep and activities of daily living, dealing with pressures of social media, screen time, substance use. How do we remedy vulnerability in adolescents who are at higher risk? We, look at whether we can do screening and brief intervention and early referral to treatment, sensitization of parents, adult mentoring, skills training, providing healthy alternatives, clinical referral when necessary, and social protections. And for treatment for people who have already fallen ill, we really need to treat them agnostically. What do I mean by agnostically? Our treatment processes are now stuck between, warring factions. There are people who live in a pharmacocentric universe and believe the dawa or the pill is the only way forward, and sneer at psychological interventions. And then there are people who are stuck in the psychological universe and who sneer at this and only believe that dua or the changing learning is the only way of doing it. I hope I would have been able to convince you that whether it is psychological, whether it is social, whether it is through the pill, all of these actually work through brain networks, changing brain networks, changing inflammatory pathways. And so it doesn't matter whether it's drug or whether it is psychotherapy. All of these additively and in combination work to change brain networks. So we really need to focus on some of these prevention frameworks: universal prevention, selective prevention, indicated prevention, etc. I'm going to go past these things. The slides are there in case anybody is interested in it. But I would do a shout out for the sustainable goals, the WHO sustainable goals, and how important it is, not just in terms of NCDs, but also especially in terms of psychiatric problems. Okay, last 3 slides. For the students there, what must we do to equip ourselves? We really need to expand our mindset. Our eyes cannot see what the mind does not know. And we need to be able to see our psychiatric disorders as disorders on a developmental continuum. And we really need to be able to see the ecological relevance of the psychiatric disorders, how they are shaped by environmental exposure and modifiable risk factors. Remember, most of these environmental risk factors are modifiable. We also need to help people derive personal meaning and look at the narratives and explanatory models that they have, which they use to deal with some of these risk factors that they have. We need to resist a pharmacocentric view of the universe. We need to be able to look at more preemptive solutions rather than the palliative solutions which we now have. Our treatments must be restorative, not only palliative and symptomatic. And most importantly, there is a need for a collaborative professional network. We need to enrich our skill sets. For the students, what does it mean? We need to understand and develop skills for developmental history taking. We need to be curious of the difficulties and distresses which are outside our job of fitting people into criteria. We need to be curious of individual personal narratives and their exposures across the lifetime, learn skills of enhancing motivation to change, reframing narratives, etc., etc. We also need to teach ourselves about a variety of treatments and therapies which are available, in addition to the pharmacocentric. Treatments which are ecologically relevant, which are available, affordable, and increase our willingness to talk about it with our patients. We must learn to work collaboratively within professional helping networks and with intersecting stakeholders like parents, teachers, socioeconomic upliftment, NGOs, etc. And we need to work backwards from the best and costliest available strategies. If we are unable to provide, at least acknowledge to the self that I'm doing incomplete work. We need to increase the congruence between what the patient wants, what the family wants, and what you have to offer. Of course, we need to influence research directions, advocacy, policy, etc. Let me end by saying that mental health disorders are shaped to a great extent by social, economic, and physical environments in which people live. Socioeconomic inequalities are associated with an increased risk of common mental disorders. Action to improve the conditions of daily life should begin from before birth, through early childhood, school age, during family building and working ages, and at older ages. While comprehensive action across the life course is needed, scientific consensus is considerable already that giving every child the best possible start will generate the greatest societal and mental health benefits. And action needs to be universal across the whole of society and proportionate to need in order to level the social gradient in health outcomes. This is basically the World Health Organization's list of demands, and I've just read them out. I will end there. Thank you. If there is time, I would be very happy to take questions. If not, people can reach out to me offline. Thank you very much.
Thank you, Dr. Benegal, for a really enriching talk. I think I really feel that after listening to Sir, what an exciting time to be a psychiatrist. I was looking at it when he started the talk, when he was talking about, the worst case scenarios, and instead of looking at it from a negative point of view, I think it's so exciting to be a psychiatrist at this point in time. So all the young psychiatrists here, so much that we can do rather than just in our OPDs and with our patients, so much of intervention preventively, right from perinatal throughout. So a great time to be a psychiatrist if we are going to be actively involved in the community. So thank you so much for that comprehensive and holistic teaching that you gave us. Dr. Ravi?
Yeah, it was very interesting talk. Dr. Benegal highlighted how we are giving too much importance to pharmacotherapy and how if you see long-term outcome, pharmacotherapy doesn't really make much difference. And he has highlighted antenatal care and early childhood care, which are very important for future brain as well as physical development. So poverty and malnutrition do play a significant role, and we have to address these issues to ensure overall development of children as adults for both physical and mental health. Now it's open to questions and answers. So any questions?
Good afternoon, sir. Sir, my question is that initially you mentioned that we need to kind of move away from biopsychosocial model, but from the talk there were a lot of points that pointed towards, again, like biological, sociological, maybe looking at the interfaces between those. So is it like an evolution from the model, or do we need to move away completely? If it is different, then how?
Okay. Thank you. That was I was hoping somebody would ask me that. When I said biopsychosocial model redundant, when we talk of the biopsychosocial model, we tend to think of these in compartments. The biology guys never talk to the sociology guys, the sociology guys never talk to the psychology guys. And that is also reflected in our practice. So when I talked about the model becoming redundant, what I wanted to actually say is that the gaps between, or the walls between these should be actually be made redundant, because sociology works through biology to shape psychology. And we now have data for that. And again, for example, when we, and this is something that we face when we are seeing patients. For example, somebody comes with borderline, so-called borderline personality disorder, EUPD. And most of the times, most people will turn around and say, hey, we have no treatment for EUPD. We can only do DBT or something like that, only do therapy. But if you look at what has caused this person to have this and the combination of problems that this person has, you will realize that the person has cognitive control deficits, which you know how to treat. If the person came with ADHD, you would know how to treat it. The person has emotional dysfunction, you would know how to treat it. If the person came with bipolar 2, you would know how to treat it. The person has, difficulties in, emotional management, emotional recognition. If the person comes with some other condition, you know how to treat it. You never put these things together because you do not see it as a whole. We have been trained to look at these disorders as separate categories and not look at the transdiagnostic deficits or the transdiagnostic conditions that occur across all these psychiatric diagnoses. And so, knowledge of how this happens, knowledge of how this is created from fetal stage, etc., how childhood adversity creates this, gives you a much larger window of intervention. It gives you a much larger understanding of what is happening. And most importantly, it equips you with a lot more tools to deal with your patient.
Thank you, sir.
Yeah, Dr. Vani, would you like to contribute?
Thank you, sir. One of my observations is that the more we say the things change, the more they remain the same. And we no longer have the multi-axial diagnosis in the ICD-11, but what you have told us is nothing but multi-axial approach to what we are doing. Having said that, there are two things that come to mind. One is that when we are looking at all the systemic things, for example, we're looking at somebody who's a person having a mental health problem, and we know that there is so much systemic issues over there. But as a psychiatrist, it is not possible for me to spread myself thin and really worried about, oh, this person is being abused, this person must go and do this, and this happened in the childhood, and they must go and get their diabetes checked. I mean, that is one of my worries. But for an average psychiatrist to manage their own stress levels, they'll have to put a boundary to how much they can think. And that is one of the practical reasons why psychiatrists rely on pharmacotherapy, because that is something they can do immediately and with greater control. Second is, the thing about children is that we have fewer children, but childhood is no longer free. If you see the facilities that we have in buses, there is a place for every kind of person, women's seat, men's seat, disabled seat. But a child who is about 10 years old, if the train is crowded, he has to ride on his mother's lap. There is nobody who is going to give him a place. So for children, I think the whole thing is now going to an issue of child's rights and the legitimacy of the role of being a child. Children are no longer free. If you see an average child, at least in an urban area, his day is completely scheduled and he is required to perform to the expectations of the society around him. He has to be very smart, he has to be busy, he has to be up to all only good things. So I think what we've set out as psychiatrists and how much stake or power do we have to preach the policy makers to make these systemic changes. So these are all the thoughts that are coming to my mind after listening to you.
He also highlighted that we have to find out what the patient wants, what the family wants, and what we can offer. While accepting our limitations, we must strive to increase our range. As Dr. Vani said, for an average psychiatric, it's not possible to go out in society and mitigate poverty and unemployment and malnutrition. But we have to find out some organizational ways and means by which we address these basic issues and we don't rely too much just on drugs. Any other question?
May I respond to that?
Yeah, please.
So, I mean, this is a conversation that we always have, because whenever psychiatrists meet, they're looking for quick fix solutions. That what can I do in my clinic? And of course, I can't do a lot in my clinic. But like I said, we really need to know what is required, what is possible, and what is the best thing under the circumstances, and then tell us that yes, we are only doing 35% of what is required to be done. That is number one. Number two is that what we as psychiatrists or mental health professionals need to do is also to interact with the other people who will do most of the other jobs that you're talking about. Poverty schemes is not a psychiatrist's job. I understand that. But you can't stop there and say, okay, so I don't have to do anything. I don't have any responsibility there. The fact that children have forgotten how to deal with boredom is probably not a psychiatrist's job, but it is definitely a psychiatrist's job to talk to parents and talk to teachers about it. So everything, reduced to a pharmacocentric, and that is my objection. Everything reduced to a pharmacocentric or a psychocentric universe has brought us to where we are right now.
Thank you. Dr. Shobha Nair.
I had one question about how you view autism, sir. The increasing rates of autism. Is it some kind of a evolutionary thing that is happening to the human species? How much is the environment and have we done it? Are we responsible for our lifestyle or how we have lived in the last 50 years responsible for what's happening? How do you view autism, sir? What has happened to our brains?
Okay, it's not just about autism. It's about changes in our brain networks, which underlie not just autism, ADHD, schizophrenia, but also underlie Parkinson's and dementia. The roots of dementia are now recognized to be very early on. And all of these are being affected by all the factors which change our trajectories of brain development. And as I showed you through some of the evidence, that exposure to, say, pollution, exposure to stress in childhood, climate change, all of these are reliably changing the structure and function of our brains, are going to worsen the change in our children and our children's children, unless we do something about it. And we can choose to sit in our clinics and say, okay, we will give chlorpromazine and this, but then you have to also deal with the responsibility that there will be increased psychopathology for our younger people to take care of. So these things are happening. And it's not just autism or ADHD, etc. There is an increase in rates of or in the vulnerability to mental illness, to cardiac illness, to diabetes, to cancer, and it works through the inflammatory mechanism, which is very common to all of these.
I think we have to re-evaluate autism and ADHD. These are clinical syndromes and need to be diagnosed clinically. It's not on symptom checklists and inter-rater rating scales. Because like a person who has fever, he will score very high on Hamilton anxiety and Hamilton depression rating scale. That doesn't mean a person with fever has anxiety and depression. So while we loosely talk autism and even sir in some of your slides, you have said that autism-like symptoms. Autism-like symptoms doesn't have any role. You have to diagnose clinically whether it is there, it is not there. You can see he has 3 out of 10 symptoms of autism, so he has autism traits. I think we have to be, we should not talk loosely and be specific about clinical diagnosis. Yes, Dr. Parker.
Great, Vivek. That was a really great talk. But I'm afraid today, the era where the pharma, is in total control of the people who need care. Basically, because it is the whole psychiatry is controlled by pharmas, right? It is the drug and the diagnosis. So in such a position, when we start taking the kind of mindset which you are telling, which is a fantastic, probably I feel it is a more philanthropic mindset, where we are looking at the changing the genetic, the DNA through, bridging the gap of the discrimination of rich and poor. We don't want, by your criteria, we don't want poverty, right? But the pharma would like to have the diseases. So what do you think the next future, it will be Mahabharat?
Trust you, Dr. Shubhangi, to come up with a question like that. No, I agree. I agree that there are lots of forces which try to keep us in the position that we are in. But some of us, you, me, we have to start talking. we have to, bring up, as I said, controversial issues. I mean, in the beginning, I said these are controversial issues, and sometimes ideas change because they start off with controversial issues. And maybe we need to start talking not to psychiatrists, but to teachers, to advocates of socioeconomic change, etc. And maybe the change will not come through psychiatrists. Maybe it'll come because we talk to other people.
It is, of course, important to talk about social change. But when I can't convince my neighbor who is floridly psychotic to take treatment, it's very, very difficult to change society. But of course, that must be our goal, to change society. And in that aspect, and the training will have to be changed. Because the training of medical health professionals, psychiatry is such that we are not trained to address these social and economic issues. That also will have to be addressed. Any other question? Anyone? Thank you, Dr. Benegal. We have been very thrilled and excited to hear from you. Thank you very much.
Thank you. Thank you so much, sir. Sir, Benegal, sir, if you can just stay online, we would like to felicitate you. I don't know how you're going to do. But can I please request Dr. Maithili Umate ma'am, our VPS EC member, to please come and felicitate sir and our chairpersons. And Shobha ma'am. Haan, but how?
Dr. Benegal, please accept this from our end. I don't know how it is.
Thank you so much, sir. Thank you so much, chairpersons. This gets us to our last session, which is a panel discussion on youth suicide. For this session, may I please request Dr. Sarika Dakshikar ma'am, who will be the moderator for this session, to please join on stage. May I also please request our panelists, Professor Shirish Kedare sir, Dr. Anjali Chabria ma'am, Dr. Aparna Joshi and Dr. Kranti Kadam to please join us on stage.